If you are over 60 and you take at least one generic medication every single day, this video was made for you. Not because I want to scare you, but because what is happening right now at pharmacy counters across America is something your insurance company will never explain. Your pharmacist may not have time to tell you, and your doctor probably doesn't even know is affecting your health decisions. I am going to change that today. In the next 20 minutes, you are going to understand exactly why your medication costs more than it did last year, what the system behind that price increase actually looks like, and most importantly, what you can do about it starting today. I am Dr. Sarah Mitchell. For more than 25 years, I have sat across from patients, real people with real lives, real families, and real budgets, and helped them navigate a healthcare system that was not built with their best interests in mind. I have seen what happens when a retired teacher has to choose between her cholesterol medication and her electric bill. I have seen what happens when a veteran quietly stops taking his diabetes medication because the price doubled and he felt too proud to say anything. And I have made it my mission to give you the information that protects you, not the information that protects the industry. This channel exists for one reason: to put the power back in your hands. If you are new here, subscribe right now and turn on the notification bell. Every week I release a new video with practical, evidence-based information for Americans over 50. No jargon, no agenda, just the truth and what to do with it. Let us start with the numbers, because the numbers tell a story that should make every American over 60 pay attention. Right now, more than 50 million Americans depend on at least one generic prescription medication to manage a chronic condition. We are talking about blood pressure medications, thyroid hormones, diabetes drugs, heart medications, seizure treatments. These are not optional purchases. These are not lifestyle choices. These are medical necessities that people cannot simply stop taking without serious consequences. And yet, over the past 3 years, the average out-of-pocket cost of generic medications in the United States has risen dramatically. For some of the most commonly prescribed generics, medications that have been available for decades, prices have not gone up by 10% or 20%. They have doubled. Some have tripled. And for a small number of critical medications, the price increase has been even more severe than that. This is happening while pharmaceutical companies report record profits. This is happening while the same medications are sold in Canada, in the United Kingdom, in Germany, for a fraction of the American price. And this is happening to people who can least afford it, seniors on fixed incomes who have done everything right and still find themselves rationing pills at the kitchen table. I want to tell you about a patient I will call Margaret. Margaret is 71 years old. She lives alone in a small home in rural Georgia that she has owned for 40 years. She worked as a school librarian for 32 years. She raised 2 children. She never missed a mortgage payment. She is the kind of person who planned ahead. She has Medicare. She has a Part D plan. She has a small savings account she built over decades of careful living. Margaret manages 3 conditions: high blood pressure, type 2 diabetes, and an underactive thyroid. All 3 of her medications are generics. Combined, they cost her around $22 a month for years. Last winter, Margaret came to her appointment, and I noticed something in her lab results that did not add up. Her blood sugar was higher than it had been in years. Her blood pressure was slightly elevated. I asked her directly, "Are you taking your medications every day as prescribed?" She looked down at her hands, and then she told me. Her pharmacy bill had jumped to nearly $90 the previous month. She had not told her daughter. She had not called my office. She had simply decided, quietly, alone, to take her diabetes medication every other day to make the supply last longer. She had been doing it for 2 months. She was not trying to harm herself. She was trying to survive the end of the month. Margaret's situation is not rare. It is not even unusual. In my 25 years of practice, I have heard this story, with different names, different states, different medications, more times than I can count. And what breaks my heart every single time is not just the financial burden. It is the silence. It is the shame. It is the fact that a woman who spent 32 years educating children felt embarrassed to tell her doctor that she could not afford her medication. That is a failure of the system, not a failure of Margaret. So let us talk about that system. Let us talk about exactly how we got here, Because understanding the machine is the first step to protecting yourself from it. When a pharmaceutical company develops a new drug, they receive a patent, a legal monopoly that gives them the exclusive right to sell that medication for a set period of time, typically around 20 years. During that window, they charge whatever the market will bear. And in America, without the price controls that exist in most other developed nations, that can be a very high price indeed. But when the patent expires, other manufacturers are legally allowed to produce the same active ingredient. These are generic medications. The FDA requires that they contain the same active ingredient at the same dose, with the same effectiveness as the original brand. The only differences are cosmetic: the shape of the pill, the color, the packaging. The medicine itself is identical in its clinical effect. This system was designed to drive prices down through competition, and for a long time, it worked. When multiple manufacturers compete to sell the same medication, prices fall. Generics now account for nearly 9 out of every 10 prescriptions filled in the United States. They have saved Americans hundreds of billions of dollars over the past decade. The generic drug system is one of the most successful cost control mechanisms in American healthcare history. So what went wrong? The first problem is consolidation. 20 years ago, the generic drug market was genuinely competitive. Dozens of manufacturers produced the same medications, undercutting each other on price to win pharmacy contracts. That competition was the engine that kept prices low. But over the past 2 decades, wave after wave of mergers and acquisitions has collapsed that competitive landscape. Today, a small number of large corporations controls the production of the majority of generic medications sold in the United States. When only 1 or 2 companies manufacture a drug that 10 million people depend on every day, those companies have enormous pricing power. There is no competitive pressure to keep costs down. There is no other option for patients to turn to, and prices go up. The second problem is geography. Most Americans assume that the medications they take are made in America. The reality is very different. More than 80% of the active pharmaceutical ingredients used in American medications, including generics, are manufactured overseas, primarily in India and China. This is not a conspiracy. It is economics. Manufacturing costs overseas were historically much lower, and the savings were passed along to consumers. But it created a fragile system, one that is highly sensitive to overseas inflation, regulatory changes, energy costs, and supply chain disruptions. When any of those factors shift, as they did dramatically during and after the COVID-19 pandemic, the cost increases flow directly to your pharmacy counter. And when overseas production of a critical medication slows down or stops entirely, American patients face shortages that drive prices even higher. The third problem is something I want you to remember the name of, because it will help you understand a lot of what you see at the pharmacy counter. It is called evergreening. Here is how it works. When a pharmaceutical company's patent on a brand-name drug is about to expire, opening the door for cheaper generics to enter the market, the company does not simply accept the competition. Instead, they make a small modification to the existing drug. Maybe they change the release mechanism so the pill dissolves more slowly. Maybe they create a new dosage form, a liquid instead of a tablet, or a patch instead of a capsule. Maybe they combine 2 existing drugs into one pill. Then they file a new patent on this slightly modified version, and suddenly, the clock resets. Generic manufacturers are legally blocked from the market for another decade or more. The medication stays expensive. The company maintains its pricing power, and patients who could have benefited from a cheap generic are instead paying brand-name prices for what is, in clinical terms, essentially the same drug they were already taking. This practice is entirely legal. It is also, in my professional opinion, one of the most significant drivers of unnecessary medication costs for American seniors. The fourth problem sits in the middle of the supply chain, and most Americans have never heard of it. Between the pharmaceutical manufacturer and your neighborhood pharmacy, there is an entire industry of companies called pharmacy benefit managers, PBMs. Their official role is to negotiate drug prices on behalf of insurance companies. In theory, they should be driving prices down. In practice, the way they operate has been the subject of congressional investigations, federal lawsuits, and growing bipartisan concern. 3 companies, Express Scripts, CVS Caremark, and Optum Rx, control the vast majority of prescription drug transactions in the United States. They decide which medications are covered by your insurance plan. They decide what your copay will be. They negotiate rebates from manufacturers, and in many cases, those rebates do not flow back to patients. They flow to the PBM. Every prescription you fill passes through this system, and at every step, there is an opportunity for margin to be extracted. Margin that ultimately comes out of your pocket. Now I want to share with you what the medical research actually shows about what happens when medication prices go up, because this is not just a financial story. It is a health story. And the data is deeply troubling. Multiple large studies published in peer-reviewed medical journals have found the same thing. When patients face sudden increases in their out-of-pocket medication costs, a significant percentage of them stop taking their medications as prescribed. They skip doses, they cut pills, they delay refills, they stop entirely. And the consequences of that non-adherence are severe and measurable. For patients with high blood pressure, stopping or reducing medication increases the risk of stroke and heart attack. For patients with diabetes, irregular medication use leads to dangerous blood sugar fluctuations and accelerates the development of complications including kidney disease, nerve damage, and vision loss. For patients with heart disease, missing cardiac medications can trigger dangerous arrhythmias or acute events. The American Heart Association has identified medication cost as one of the most under-recognized risk factors for poor cardiovascular outcomes in older Americans. Research published in leading geriatric medicine journals has found that seniors who ration their medications due to cost are significantly more likely to end up in the emergency room within months. Not because their disease got worse on its own, because the price of their medication went up and nobody gave them a better option. This is the hidden cost of rising drug prices. It does not show up in pharmaceutical company earnings reports. It shows up in emergency rooms. It shows up in ambulances. It shows up in the gap between how healthy a person could be and how healthy they actually are. And it is preventable. So let us talk about prevention. Let us talk about exactly what you can do, starting this week, to protect yourself. The first strategy is one that requires a conversation with your doctor, and I want you to feel completely empowered to have it. It is called therapeutic substitution. Here is what that means in plain language. Most medical conditions can be treated by more than one medication. High blood pressure, for example, can be managed with many different drug classes: ACE inhibitors, beta blockers, calcium channel blockers, diuretics, and more. Within each of those classes, there are multiple individual medications. Some of those medications have generics that are very inexpensive. Others have generics that have experienced significant price increases. If the medication you are currently taking has become expensive, there may be another medication in the same drug class, equally effective for your specific situation, whose generic is currently much cheaper. Your doctor can evaluate whether a switch makes clinical sense for you. This is not settling for a lesser medication. This is smart, informed healthcare. Walk into your next appointment and say these words: "My medication costs have gone up significantly. Is there a clinically equivalent alternative in the same drug class that might cost less right now?" Any physician who is working in your best interest will take that question seriously. The second strategy costs you nothing and takes about 3 minutes. It is called Good RX, and if you are not using it, you are very likely overpaying for your medications. Good RX is a free service, available as a website at goodrx.com and as a smartphone app that compares the price of your specific medication at every pharmacy in your area and provides you with a coupon that reduces your price at the counter. Here is the part that surprises most people. In many cases, the Good RX price is lower than the copay on your Medicare Part D plan. That means showing a Good RX coupon at the pharmacy counter can save you more money than using your insurance. I have had patients save 50%, 60%, even 80% on medications they had been overpaying for years, simply by downloading a free app. Before you pay for any prescription, check Good RX. Every single time. It takes less time than it takes to find your insurance card. The third strategy requires action once a year, but it can save you hundreds of dollars annually. Every year between October 15th and December 7th, Medicare holds its annual open enrollment period. During this window, you have the right to switch your Medicare Part D prescription drug plan. This matters because drug formularies, the official lists of which medications each plan covers and at what cost, change every single year. A plan that covered your medications cheaply last year may have restructured its formulary this year in ways that significantly increase your costs. Most people do nothing during open enrollment. They let their plan auto-renew and assume the coverage is the same. It often is not. Go to Medicare.gov and use the Plan Finder tool. Enter your zip code and the specific medications you take. The tool will show you every available plan in your area, what each one would cost you for your exact medications over the course of a year, and how to switch if you find a better option. Spending 1 hour on this exercise during open enrollment can save you $300, $500, even $800 or more over the course of the following year. The fourth strategy is one that your doctor and pharmacist may already use themselves, and it is simple enough to explain in 2 sentences. For certain medications, and I want to emphasize that this does not apply to all medications, so please verify with your physician or pharmacist before trying it, a tablet at double your prescribed dose costs nearly the same as a tablet at your actual dose. By purchasing the higher dose tablet and splitting it in half with an inexpensive pill cutter, you effectively get twice as many doses for roughly the same price, cutting your per-dose cost in half. This is called pill splitting, and it is a legitimate, widely used cost-saving strategy. The important caveat: this absolutely does not apply to extended-release tablets, enteric-coated tablets, capsules, or any medication where the release mechanism is part of how the drug works. Splitting those medications can be dangerous. Always ask your doctor or pharmacist, is my specific medication appropriate for pill splitting? If the answer is yes, a $3 pill cutter from the pharmacy can save you hundreds of dollars a year. The fifth strategy is the simplest change you can make with the longest-term impact. If you are on a stable, long-term medication, one that you have been taking for months or years at the same dose, ask your Medicare Part D plan about their mail-order pharmacy option. Medicare Part D plans are required to offer mail-order pharmacy services, and they almost always provide a 90-day supply of medication at a meaningfully lower per-unit cost than a 30-day retail fill. You get more medication for less money, delivered to your door, without a monthly pharmacy trip. For patients on multiple long-term medications, switching to mail order can reduce annual out-of-pocket drug costs by several $100s. It is one of the easiest, lowest-effort changes you can make, and most people eligible for it are not using it. Now I want to talk about your rights, because beyond strategies, you have legal protections under Medicare that the system does not go out of its way to advertise. The first right you need to know about is your right to file a coverage exception. If your Medicare Part D plan does not cover a medication your doctor has prescribed, or covers it at a very high cost tier, you are not simply stuck with that outcome. You have the right to request a formal exception. Your physician submits documentation to your plan explaining why this specific medication is medically necessary for your situation. In many cases, particularly when there is solid clinical documentation, these exceptions are granted. The medication gets covered at a lower cost tier. This process takes a little time and requires your doctor's participation, but for expensive medications, the financial outcome can be significant. If your plan denies coverage for something your doctor prescribed, do not simply accept that. Ask your doctor about filing an exception request. The second right is one that over 1 million eligible Americans are not currently using, simply because they do not know it exists. It is called the Low-Income Subsidy, and Medicare refers to it as Extra Help. This federal program provides substantial assistance with prescription drug costs for Medicare beneficiaries who meet certain income and asset thresholds. If you qualify, Extra Help can reduce your premium, deductible, and copays to near zero. The income and asset limits are higher than many people expect, meaning some people who assume they would not qualify actually do. The Social Security Administration administers this program, and you can apply directly through them. At your next appointment, ask your doctor's office if they can help you determine whether you might be eligible. This is money that exists specifically to help people in your situation. Make sure you are not leaving it on the table. The third right became law through the Inflation Reduction Act, and it represents the most significant change to Medicare drug cost protections in many years. Beginning in 2025, Medicare Part D enrollees have a hard annual cap on out-of-pocket prescription drug spending. Once your out-of-pocket costs for covered medications reach that cap in a given year, your plan covers 100% of additional drug costs for the rest of that year. This is a meaningful protection, particularly for people who take multiple medications or who take expensive specialty drugs. Know what your plan's out-of-pocket tracking looks like. Know when you are approaching the cap. Your plan is required to notify you, but staying informed and proactive is always in your best interest. Let me bring this all together for you. The rising cost of generic medications in America is not an accident. It is the predictable outcome of a system that allows market consolidation to eliminate competition, that depends on fragile overseas supply chains, that permits pharmaceutical companies to extend their pricing power through legal patent strategies, and that allows a small number of largely unaccountable middlemen to extract billions of dollars from the prescription drug supply chain every year. None of that is your fault, and none of it means you are powerless. You now have 5 concrete strategies. Ask your doctor about therapeutic alternatives. Use GoodRx every time you fill a prescription. Review your Part D plan every October during open enrollment. Ask about pill splitting for eligible medications, and switch to 90-day mail order for your stable long-term medications. You also have 3 legal rights under Medicare that most seniors never exercise: the right to file a coverage exception, the right to apply for extra help through the low-income subsidy program, and the protection of the annual out-of-pocket cap established by the Inflation Reduction Act. You walked into this video not knowing any of that. You are leaving it knowing all of it. That is the difference between being a passive participant in a system designed to extract money from you and being an informed, protected, empowered patient who knows exactly what questions to ask and exactly what tools are available. Use this information. Share it with someone you love. And come back every week, because this is what this channel is here to do. If this video helped you, please give it a thumbs up. It costs you nothing, and it helps other Americans over 50 find this information when they need it most. Drop a comment below and tell me, have you noticed your generic drug prices going up in the last year? Write yes or no. I read every single comment personally. And share this video with a friend, a neighbor, a family member over 60 who fills prescriptions every month. This information could make a real difference in their financial life and their health. I am Dr. Sarah Mitchell. Stay informed, stay protected, and stay independent. Always consult your own physician or healthcare provider before making any changes to your medications. This video is for educational purposes only and does not constitute medical advice.